Welcome, everyone. I think most of people have come in from the lobby. So I'd like to welcome you all to the Monash Health COVID Care Pathways webinar for GPs. My name's Dr. Alan Andrews. I'm in the GP Liaison Unit at Monash, and I'll be the chair this evening. I'd like to commence this evening by acknowledging the traditional owners of the land on which we are meeting. I pay my respects to their elders past and present, and the elders from other communities who may be here today. Assisting with running this evening is the Monash GP Liaison Unit Coordinator, Margaret Ricardo, and also Monash Maternity GP Liaison, Dr. Rebecca Fradkin. So thanks to Rebecca there and Margaret, who have given you a bit of a wave. Now, just a little bit of housekeeping. There's a chat function on the bottom right of your screen. So that's where you'll be able to communicate either with each other or pose some questions to the panel. We will ask you to hold your questions potentially to the last speaker so that we can address them towards the end of the session. And you may find the panelists will cover the question as we move forward anyway. So we're probably going to try and fit in quite a lot this evening. So without further ado, we'll move on to the first of our fantastic panel of presenters. And our first speaker tonight is going to give you an overview of the home-based COVID care. And that's Associate Professor Ben Rogers, who's an infectious diseases physician and the head of unit at Monash Hospital the Monash Hospital in the Home. So Ben, I'll hand over to you.
Look, thanks so much, Alan, and thanks for having me speak today. And it's amazing to see so many people on. And I'm actually seeing some faces of people I've spoken to a lot on the phone, speaking to GPs, and it's nice to put faces to names. So let me pop up my slides, which are here. Can all of you see that? Yeah, great. So I'm an infectious disease doctor. I'm the medical director of Hospital in the Home and COVID Pathways at Monash. And what I'm really here to do today is just to kind of give you a high-level view of how the pathways work, acknowledging that amongst the group listing, there'll be probably people who know an awful lot about this and people who don't know much about it. So it'll be too much information for some and not enough for others. Let me just keep this moving if I can. So in my overview, I'm going to give you a general structural overview of the pathways and then talk a little bit about the medium pathway, which is a terrible name, but it's the pathway run by our team at the health service. And Benj is going to tell you a little bit more about the low pathway, again, another terrible name, which is run by the, in the community, by our community partners and by all of you as GPs. So I'll talk a little bit about just the background and the evolution. I really want the message to come across as to why, we value your engagement so much and why it's so important to have you coming on this journey with us. I'll touch on a few slides about what happens in the medium pathway. And I'll also acknowledge, some limitations about what we do and also talk about future plans. And this has really been an incredibly moving feast. It's been changing at such a rapid rate that today's slides won't be current tomorrow. So the basic premise of the pathway is that the best place to care for people with COVID, or most people with COVID, is in the community. Now, this is not something that's been taken up by all jurisdictions in Australia or globally, but for those of us that work in this space, I really believe that's important. The place for people with COVID, where possible, is in their home, in the community, rather than in a hospital. But in fact, to do that, COVID poses really unique challenges that a lot of other, traditional infectious diseases, influenza, diarrhea, don't really have. For the patient, this has been a completely new illness. Nobody really understood the trajectory or the symptoms, whereas if somebody had the flu, they kind of knew what was going to happen. There's a lot of psychosocial overlay and challenges, a lot of stigma and other things that don't come with other traditional, flu and other diseases. There's these public health and isolation requirements, which really just complicate everything incredibly. And the other thing that really has been a learning experience for us in the ambulatory care space is that, COVID is really a disease of the household unit. Regardless of how many people in the house have COVID, be it one member or all the members, the entire house is disrupted. And, the whole social fabric and structure and interactions are disrupted. So these are at a patient level, some of the challenges with caring for people at home. And I guess at a system level, at a health service and community practitioner level, the isolation and transmissibility really pose a lot of challenges for us. Our usual model is to bring the patient to us, bring the patient to a GP clinic, bring the patient to a hospital, but we really try and avoid doing that in this setting. The clinical trajectory is also really quite unique compared to other things we look after. If somebody turns up with flu, you're kind of seeing them usually at their sickest. Whereas usually when somebody turns up with COVID, they're going to be sicker 5 or 7 days later than when they present. There's also a risk of very rapid deterioration, which we don't see as often in other illnesses. And this is all layered on top of what really has been a rapidly evolving understanding of the disease and the emergence of a number of disease-modifying therapies and symptom management and other things. So these are all really challenges we've had to tackle in this community pathway. So the pathway itself was initiated by the Victorian Department of Health. It evolved from a few pilots and programs at local health services. Monash participated in one. Royal Melbourne did a very large one, which was the basis of a lot of it. It kind of started in the third quarter of last year, but we kind of all took a little bit of a breather when things settled down. But it really has been in sharp focus and the recipient of a huge amount of energy and passion since I've said 20, I've got my years wrong there. I'm usually a year behind, but in fact, I'm a year ahead this time, by mid-2021. And there are many parties supporting it, but kind of at a higher level. I can see Beck still laughing at that. If only it was 2022. Really at a higher level, this is very strongly supported by the Victorian Department of Health Pathways team. In that, it's important to know that that team that looks after the pathways is actually a little bit gapped from, the contact tracing and outbreak management, the public health team. So you're either speaking to one or you're speaking to the other. So sometimes things don't always communicate as expected. We've had involvement from Safer Care Victoria, and we've had involvement from some consultants externally as well who've supported some bits of it. At a service delivery level, it's been supported by really primarily funding from the Victorian, Department of Health COVID funding, and obviously federal funding for the GP service. And really, without going into too much detail, the aims of this pathway are really pretty simple. They're all about supporting patients in the community, keeping patients in the community when it's safe to keep them there. So, that includes reducing the patient's illness burden, making sure they're as comfortable as they can be despite having what can be a really unpleasant illness, reducing unnecessary ED presentations. So, keeping people at home when they can be at home, and also facilitating the patient containing the public health risk, making sure that they don't need to go out unnecessarily. The flip side of that coin is also ensuring that patients who require hospital care receive it. And this is really quite an important thing. This is about getting patients into hospital in a safe and planned presentation before they reach a critical illness. An institution of disease-modifying therapies, typically in hospital when the patient reaches that point. So they're really the yin and yang of the pathway, keeping those that can be at home and bringing those that need to be into hospital. But we kind of think of ourselves as concierges. We like to kind of concierge the patient into hospital in an organised manner. And there is, in fact, which came with some vision from those that designed it, a longer term aim here, which is really making sure that the patient who has COVID engages in healthcare and has some ongoing support for their COVID, after they're cleared of the illness. As we know, there are often, prolonged symptoms and prolonged issues which need managing and or follow-up for vaccination. And also maybe at a higher level, really seeing if, by bringing patients to their GP with this acute illness or to the health service with this acute illness, we can really engage them better in healthcare moving forward. So how do we do this? So this is a very busy diagram, and this is kind of the high level view of the pathways, and I'm going to talk through it and then blow up some bits. But essentially, what happens from end to end is the patient has a COVID test anywhere. And as you may all know, every single COVID test in Victoria now gets funneled through to the Department of Health. Those positive tests that fall within the South East Public Health Unit catchment get funneled back to the South East Public Health Unit, which is where we all sit. And that includes the cluster of Alfred, Peninsula Health and Monash Health. So South East Public Health Unit then undertake their public health actions on these positive tests, which is completely separate to the pathway. And then these positive tests also get handed on into this pathway stream, which is where we really get involved. Now, within the stream, the first thing that happens is this self-reporting and dynamic prioritization. And I'm going to blow up this blue box for you in the next slide, because it's worth community practitioners having a bit of an understanding of how this works. But essentially, patients go into this dynamic space where they're prioritized and self-report their symptoms. Those that need to then move into the pathway proper. And when they move into the pathway proper, the first thing that happens is that they have contact with an intake person who, on the phone, takes a structured medical history, looking for risks of deterioration, looking for their vaccination status, their age and comorbidities, and also a structured symptom history. And from those two things, essentially, we stratify our patients into three distinct groups. The first group are the low severity patients, who are the patients that have, mild or moderate symptoms and do not have factors that suggest that they're at high risk of deterioration, hospitalization and death. Those patients are then handed off to what we call the low care pathway, which is managed by yourselves as GPs in collaboration with our community partners, who have just done an amazing job in this. So that's the low care pathway, which you'll hear more about. The medium care pathway, which is where myself and my colleagues sit, are the patients who either have significant comorbidities, so they're at high risk of deterioration, often unvaccinated as well falls in there, or they've got very significant symptoms. And they come across to the medium pathway, which in the Monash Health jurisdiction is a nursing-led complex care CART type pathway, but in the Alfred Health and Peninsula Health jurisdictions, they have slightly different structures. Alfred is a bit more of a medically led pathway, and Peninsula Health is a bit of a hybrid. And then there's a small proportion of patients that are identified on that initial contact as needing hospitalisation, and they're dispatched to hospital. So that's how the stratification works. When you look at all the patients that funnel to this point of the intake, typically, about 20% of them will end up in the medium pathway, 5 or 10% will end up in the high severity pathway, and 3/4 of them will end up in the, the community or low severity pathway. The movement between these pathways is dynamic, and we'll talk about that. So patients in the low pathway can come to us if required, to the medium pathway if they've got more symptoms or there's something that hasn't been identified on that initial intake. And obviously patients transit, and one of the key aims is, this organised transit between, the community care here and the hospital care in the high care pathway. And then at the end of all of this, patients are discharged. It's not really 14 days anymore. They're discharged at 10 days from the primary care pathway. The medium care pathway is on an as-needed basis, usually between 10 and 14 days. And then they go on to post-COVID care. So just to blow up that little box about the self-reporting and risk stratification, and to explain it, as I said, the patient gets a positive test, and when the positive test comes to the COVID pathways, the first thing we do is we send the patient an electronic survey via SMS. And that survey basically says, you have COVID, please tell us a little bit about yourself. And in that survey, we find out about the patient's symptoms, we find out about their vaccination status, and we also find out very generally about their comorbidities or if they're pregnant. And essentially from these 3 bits of information, we put the patient in one of 2 groups. The first group are the group that we're concerned about, they're not okay, and they come through to the pathway proper here, where they get the intake assessment. And the second group we think are okay to keep really self-reporting and self-monitoring. And then they continue to get daily messages and continue to self-report symptoms to us. This is a dynamic system, so if their symptoms escalate, and they get high symptomatology and become not okay, then they get bumped up to this intake and they come through the pathway proper. It's worth you knowing about this, and I'm sure a number of you have had patients already present to you that are self-reporting symptoms, and they may well, they may well come to you with regular problems or with COVID whilst they're in this self-reporting space. And in fact, we give them advice on the SMS that they can contact their GP. So that's the dynamic prioritization, which is where patients kind of sit in the community. In terms of how we do that prioritization about who comes into the pathway proper and who stays in this self-reporting group, and how quickly we do that, this is what we use. And essentially, without going into too much detail, if you have severe symptoms, you're over 50 and incompletely vaccinated, or you're pregnant, then you're contacted very quickly. We want to get your information, we want to get you into a pathway. If you have some comorbidities, or you haven't responded to our survey, so we don't really know much about you, then we try and contact you within 24 hours. And then these P3 and P4 categories are those that we're not too worried about. And at the moment, we don't contact them at all. They just continue self-reporting to us. So this is the whole pathway that I've talked about. And just to remind you, what I've talked about falls in here, and then patients move through to one of the pathways. Or if they're well and they're self-reporting, they stay in this group and they don't progress at the moment. So as I said, my role is really in the Monash medium pathway, which is looking after the patients who either have severe symptoms or comorbidities that suggest they're at high risk of progress. Our pathway, is run really by a huge team, and I should have acknowledged that at the start, that I'm really here, talking for an incredibly, dedicated team of nursing staff, allied health staff, support staff, medical staff who are doing all of this. We kind of have a nurse-led model, led by nurse practitioners and complex care nurses with a lot of seconded nursing staff, a number of seconded allied health staff supporting us. We have medical support for that model with ED and infectious disease doctors. And basically we do symptom monitoring on this electronic portal or by phone if the patient doesn't want to use the portal, self-collected observations with an oximeter. We can do face-to-face reviews if required. If there's something complicated to sort out with the patient, we assist patients in managing their comorbidities, be it their diabetes, their asthma, whatever it is, and we provide a lot of psychosocial support. So for a patient, really, this might look like this. Twice a day, they'll ping us their symptoms on this on the app that we use and their observations. So all our patients in the medium pathway get an oximeter. Patients in the low pathway shouldn't need an oximeter, the ones cared for in the community. We make daily telephone contact with the patients. This is education, information, medical and psychosocial support. If it's required, then the nursing or allied health team that make daily contact escalate to the medical team or the nurse practitioners, and we can undertake a phone or telehealth review, or the nurse practitioners can go out as stated. We can prescribe medications, we can organise modifications of routine medications. We're often giving symptom management, antiemetics and other things. And now we're just moving into the space of being able to prescribe disease-modifying therapies as well, which we're not talking about too much tonight, but things such as budesonide and others that are coming along. And when required, we organise transfer to hospital. So how's it going? I'm probably running out of time, but really to say, at our peak across the Southeast Public Health Unit catchment, we were getting almost 2,000 patients a day coming into this pathway. So this has been a massive load of patients coming in, and we've kind of settled back down now. But this is today's numbers. So we had over 500 new patients allocated today to our catchment. And if you have a look at the numbers sitting in each of our pathways, we're running at hundreds and hundreds of patients in each pathway. So we continue in the medium pathway and through the low risk pathway to support a very large number of patients in the community. What's going to happen from here? So there's a few things going on which will hopefully help everyone, including patients, yourselves and us. One of which is there's a move towards standardizing what happens across all the different pathways. So each health service has its own pathway, but we're working to standardize our procedures, standardize our use of the COVID Monitor electronic platform. We're working incredibly hard, really to support GPs, to get you engaged. And this is something that really we were slow to the party with for various reasons. We're working on how best to notify you when patients come to us or of positive tests. We're increasing our clinical support for community GPs when you're looking after COVID patients, and really aiming to increase our collaboration in this space. I mentioned disease-modifying therapies, and there is another group that is going to come into this pathway, and there will be some more information about this as it happens, but there is a small group that is probably going to be identified as low enough risk that they won't even go into the self-reporting prioritization category. And that's probably going to start in a few weeks, but you will hear some more information. This is a statewide initiative rather than something led by us. So look, these are kind of really the key members of the team I want to thank. Our incredible nursing leads, Rula, who's our clinical lead and ID physician, Sarah, who's our operations lead, and really our partners. Central Bayside have been our community partner, and Alfred and Peninsula Pathways teams we work incredibly closely with. But look, thanks all for listening, and I'm really excited to hear the other speakers.